Chào mừng các bạn và các anh chị đã đến với kênh YouTube của bác sĩ Nhân da LIểu, với mong muốn giới thiệu và chia sẻ một số kiến thức về da, bệnh của da, cách điều trị và chăm sóc, đồng thời học tập, trao đổi và chia sẻ một số vấn đề liên quan đến thẩm mỹ da nội khoa, và đặc biệt là cập nhật các chuyên đề mới trong da LIểu. Nếu thấy nội dung kênh hay và hữu ích, mình xin nhận được sự ủng hộ từ các anh chị và các bạn. Nào, giờ chúng ta sẽ đến với chủ đề hôm nay nhé.
Chào các bạn. Phương pháp trẻ hóa da mặt là phương pháp tác động vào làn da bằng cách tự nhiên hoặc thẩm mỹ để phục hồi hoặc giảm bớt dấu hiệu lão hóa, khắc phục các khối cơ bị chùng nhão, chảy xệ, kéo căng các mô da, hạn chế nếp nhăn, từ đó giúp da lấy lại vẻ săn chắc, căng mịn và tươi trẻ. Đến với video hôm nay, mình xin giới thiệu đến các anh chị và các bạn các phương pháp trẻ hóa và định hình da mặt nằm trong chuỗi chuyên đề thẩm mỹ da nội khoa của mình. Giờ không để các anh chị chờ lâu, mình đến với chủ đề hôm nay nhé.
Alright, this treatment involves a 36-year-old female, and when I ask her pre-treatment what her primary goals are for undergoing injectable treatment, she mentions two main things. The first is that she feels she looks older than she actually is. She's 36 years old and she feels like her face portrays an age that is beyond that. Secondly, which is a very common presentation or complaint for patients, is that of feeling like they look tired. And several different emotions can be expressed through our face, of course, and generally we want to express positive and not negative expressions such as tiredness, anger, or sadness. And when we look at this patient, we really see that the face is marked by volume loss in several different areas. Our treatment plan usually consists of starting in the mid-face and trying to add support to the zygomatic region of the face in order to both add volume here as well as lifting capacity towards the entire lower part of the mid-face and lower face. For this patient, we will start by treating the mid-face and move towards the more medial aspect of the mid-cheek, and then work in the preauricular area where we see volume loss, and then complete our treatment by adding some strength to the chin, which is slightly small and retruded, as well as accentuating the lips. The most important areas for this 36-year-old young woman are going to be improving the prominence of her zygoma, as well as improving the mid-face. That is going to have a huge impact on her whole periorbital region and help take away that look of tiredness or of age. A couple of the unique features we see in this patient is in the temporal area. Most patients will have a little bit of concavity here that we are trying to volumize. In this patient, we can see a very strong temporalis muscle. Can you bite down for me? We can see the strength of this temporal muscle, and in her you can relax now. We actually want to soften that transition between the frontal bone and the insertion, that broad insertion of the temporalis muscle. So we'll be injecting that in a little bit of a different fashion than we typically would for the temple. When we are thinking about the vascular anatomy of the face, we need to also appreciate that there is a great deal of variability in this, and what we may see in a textbook or draw out on the face may not exactly correspond to what is going on in reality. Having kept that in mind, we do want to avoid the major neurovascular structures whenever we are injecting. Of concern whenever we are injecting in the upper face and forehead are the supratrochlear and supraorbital arteries. The supratrochlear artery is generally landmarked at the medial portion of the brow, approximately 2 centimeters from the midline. Our supraorbital artery generally comes from a notch that is palpable along the junction of the medial and lateral 2/3 of the orbital rim. Oftentimes, there is actually a deep and a superficial branch of these arteries, but traditionally they are described as coming from the level of the periosteum, exiting the bone, going through the corrugator, and then starting to migrate superficially as we transition to the upper part of the forehead, where they pierce the galea and then go superficial to the frontalis in a subcutaneous plane. So we know the artery down here is deep, and as we come here, it's more superficial. We must keep that in mind when injecting anywhere in the forehead. Along the infraorbital region, we are always concerned about the infraorbital artery and infraorbital nerve, which are typically located about 1 centimeter inferior to the orbital rim and approximately in line with the medial aspect of the pupil. The most important anatomic structure when we are talking about the mid and lower face is the different branches of the facial artery. The facial artery is generally palpable at the anterior edge of the masseter muscle. Can you bite for me? I can palpate her masseter here, Generally, right anterior to that, we can palpate the facial artery. The facial artery has a great deal of variability in both its course and its distribution in different patients. It is a tortuous artery, that is a branch of the external carotid artery, and has several important branches. As it extends forward across the face, it typically gives off an inferior labial and a superior labial branch. This is usually actually a little bit more medially than is shown and is generally in the area of about 1.5 centimeters lateral to the oral commissure. In different patients, varying branches will then continue up the upper part of the face. Typically, this is described as an angular artery, which has a junction with the internal carotid system as it courses superiorly. And this can give off an inferior alar branch, a lateral nasal branch, which is the predominant blood supply to the nasal tip. From the superior labial artery, we will see a columellar and a septal branch coming forward this way. And we see in the nasal area that there is a dorsal nasal artery, an external nasal artery, which is a branch of the ethmoid artery, and then the columellar arteries coming this way. And this will be of more relevance when we are injecting the nose. We discuss these different arterial locations because when we are treating any of the anatomical structures in this region, we want to minimize the chance of intravascular injury. Thus, we will typically use a blunt cannula, either a 25 or 22 gauge. The larger bore, the less likelihood of penetration. And we are also being much more cognizant as we inject in terms of plane and depth of injection. Our landmarks for treating the midface are different in male and female patients, and also of patients of different ethnicities and backgrounds depending on their face shape. Typically, we want to get the most amount of elevation laterally as possible. We know if we can do what my finger is doing, this is going to improve the entire mid-face region and even lower face region. Of course, this is an exaggeration, but that is the effect we wish to create. We palpate the zygoma. That's a palpable bone as it comes across here, and we can feel the top and bottom of the zygoma. And we want to palpate for the suture line between the zygoma and the temporal bone behind it. So we look for the temporal-zygomatic suture line, and we'll place a point there as our first injection point. The second point will be the malar eminence. It's the lateralmost projection point in the face, and we want to create elevation in this region. And that will be our second injection point to try and create more definition of the lateral portion of the midface. Our cheek highlight is an oval, and it's an eccentric oval with maximal diameter that occurs in the apex of the cheek. This is different in different patients, but in this young patient, this is typically the area we wish to accentuate with our injectable. This portion of the treatment is done with needle, and the lateral point is selected first. It is retracted back, and our needle is passed straight down onto periosteum. The injection is very slow in order to avoid dispersion of the product. Rather than a true volumizer, here we are using it as a tent pole or as a support pillar to elevate the lateral portion of the face. Our first injection point, we've used 0.1 cc's. We then do some slight light massage and move to our second point, which is further anterior. This again is right on a periosteal level or pre-periosteal level. As we slowly inject, typically a volume of between 0.1 and 0.3 cc's. And now we observe what type of improvement we have and what type of elevation we have before proceeding further. So we've already started to create some definition of the apex of the cheek. We are going to further want to enhance that by adding more volume throughout this oval complex at our cheek apex position as we continue further. During our analysis, we noticed a very prominent temporalis muscle. This creates a ridge along the temporal fusion line. Can you bite down again for me? That we can see extending all the way across the attachment of the temporalis muscle. This area can be treated with needle or with cannula. In this particular case, it is a little bit different than our typical treatment for most females in the temporal region, where we're trying to inflate or add volume to the temporal fossa. Here we're trying to smooth the transition down. For this patient, I'll be using voluma on a needle straight down on the periosteum, right at the level of the temporal fusion line. We must be cognizant of the superficial temporal artery and its branches as they cross forward across the forehead. They do anastomose typically with the supratrochlear level and thus do have communication with the ophthalmic branch potentially. The injection point selected will course just along this fusion line in a deep level and a very slow injection. And then the product will be molded. Here I'm using voluma in small aliquots. And this will be blended and massaged in order to create a smoother transition between the muscle and the bone medial to it. So again, here we're not trying to volumize, we're trying to camouflage. The last point of injection in the temple is actually going to be to actually add some volume there. The goal of this injection point is going to be to raise the tail of the brow slightly. We can see in this patient the brow is quite flat and has a little bit of ptosis along the lateral aspect. We would like to support that with our injectable, in this case voluma. Our injection point is going to be approximately 1 centimeter inferior to the temporal fusion line and 1 centimeter above the supraorbital rim as described by Arthur Swift. In this area, again, we want to avoid the deeper structures of the temporal fossa, the anterior and posterior branches of the middle temporal artery and the deep temporal artery, which are much larger caliber inferiorly than they are superiorly. We also want our product to have maximal effect with minimal amount, and thus we do not want to be inflating the entire temporal region, especially in this patient, but rather just create support of the brow and improve the transition between the temporal regions and the brow regions. So we pick that point, which is right about here, and our injection is right down at the level of periosteum again. We are right down, our needle bore is touching periosteum. The injection is performed in a very slow manner, and pressure is maintained inferior and lateral to our injection point to avoid our product from dispersing into an area where it will not have the intended effect. 0.2 cc's were injected in this region. Again, care was taken not to accentuate or create further enlargement of the temporalis muscle, which would be contraindicated for her. Our next focus of treatment will be to continue to improve the lateral malar region of the cheek, as well as the medial portion of the cheek and the infraorbital region by adding support in the SOOF layer. The infraorbital area is bound by a tear trough ligament and an orbicularis retaining ligament which extends laterally and creates the infraorbital hollow in certain patients. For this younger patient, we do not see a truly defined groove in the infraorbital hollow, but rather we see lack of support in the SOOF layer, which is bounded superiorly by the orbicularis muscle, up at the orbital rim by the tear trough ligament itself, and bound medially by the angular vessels. Because of the vessels, the infraorbital and angular vessels in this region, we will treat with a cannula. The lid cheek junction is marked out so that we can see exactly where we are injecting and what our goals are. Our goals are to reduce the distance between the eyelid and the cheek and reduce the transition that is occurring between these two levels. A 25 gauge cannula has been selected for this, and VoLift is the product that we are using, which is also known as Volure in the United States. Level of injection is just above the levators of the upper lip, deep to the orbicularis muscle, in the level of the SOOF. The cannula, which is exaggerated here, can be seen in this level, and it is passed in a fan-like fashion. Or if a heavier HA is selected, a bolus fashion is also very effective in order to add support. Typical volumes in this region range from 0.1 to 0.5 cc's. In this patient with quite a bit of volume loss, 0.5 cc's have been used. The product is molded upwards in order to try and support the eyelid. And typically we will see a decrease in the lid-cheek junction length compared to the contralateral side when the support is ideal. Through our same entrance point, we are able to address the lateral portion of the orbital rim. This is particularly important if we are to augment the zygomatic region. We do not wish to create an unnatural transition between the orbital rim and the cheek. The cannula is advanced and the patient is warned of a slightly tighter feeling in this region due to the adherence of the orbicularis retaining ligament, as well as the passing of the cannula through the zygomatic cutaneous ligaments in this region. The cannula is seen and also palpated in the right level along the orbital rim. This can be further accentuated for us visually by having the patient look up to the ceiling with their eyes. And we can see the border along this more clearly. Here we are using Volift in very small aliquots, which is injected right along the margin of the infraorbital hollow, the lateral portion of it. It is important not to inject right onto the orbital rim into a postseptal area or above the orbicularis retaining ligament, for this can cause prolonged edema and swelling, which can be very difficult to treat. In this patient, we're trying to improve the flatness of the lateral canthal area as my cannula further advances to the corner of the eye. After achieving support with Volift, we are now using Volbella, which is a very thin and less hygroscopic hyaluronic acid filler. This will be the true injectable hyaluronic acid injectable that we will be injecting across the actual hollow itself in the tear trough ligament region and orbicularis retaining ligament regions. This injection is more superficial. We can see the cannula passing right into and through the tear trough ligament. This is a true ligament, thus it is impossible to be actually underneath the ligament or injecting below it. We almost need to inject through it. And we will inject right along that lid-cheek junction and infraorbital hollow to try and improve the transition for us here. Again, to improve our visualization, we will have the patient look up with her eyes, and that accentuates the transition between the lid and the cheek. And it also highlights any fat pseudo-herniation of the lower lids. I'll take gel next, please. Typically, less than a half cc is used per side for most patients, anywhere between 0.1 and 0.5 cc's. In this patient, we have used 0.5 cc's. A small amount of ultrasound gel or a cotton tip applicator can be used to roll this region and ensure a smooth transition. Injection is placed as deep as possible in order to avoid the appearance of edema post-procedure or of Tyndall effect with the hyaluronic acid reflecting or dispersing light through the skin in an unnatural manner, causing a gray or bluish hue. We'll use Voluma to augment the cheek in a deep layer. Here we are using a 2-inch cannula or 50mm cannula to be able to address the entire cheek region. With our pre-marked defined areas. Typically between 0.1 and 0.4 cc's are used in this region. So at this stage, what we have accomplished is a smoothing of the periorbital area, enhancement of the zygoma, and enhancement of the mid-cheek and the medial aspect. Next, we will see the hollowing and address the hollowing of the lower part of the submalar region and preauricular region. We can see that this is actually highlighted or enhanced further by treatment of the upper portion of the cheek, which creates more of a discrepancy. Thus, this is an area to ensure that is not ignored. The additional benefit, in addition to improving the shadowing and sulcus, is an elevation or lift when the submalar areas are treated to help the jawline. When we observe the lower portion of the submalar area, we see two areas of deficit. The first is in the area of the buccal fat or buccal space, and the second is in the preauricular or preparotid regions, where we see deficiency below the zygoma. These areas are slightly different. Here we do have a deep plane which is overlying the parotid gland itself, and we have a lot of mobility here, which is nice. We'll be able to treat that well with a deep filler. But we also see volume loss in the buccal region, which is a little bit more difficult to treat as we do not have a backstop against this. This is a void or open space where her teeth are. Both of these areas are treated with a cannula, and we'll select a point that will allow us to reach both anteriorly and posteriorly. We will be using voluma in the posterior aspect and something slightly softer such as Volift in the anterior aspect. We will start by treating the posterior preparotid region and preauricular region. This is an area that is quite adherent, as there are attachments between the parotid gland, just over the deep parotid fascia, through the smaz, into the skin as well, and thus we feel more fibrous type of sensation as we pass the cannula through here. In this patient, she actually has excellent mobility through here, and we are fanning our treatment through, injecting in an anterograde fashion to minimize pain as we work, taking advantage of the lidocaine. This area can typically take anywhere between 0.2 to 1 cc because it is a broad area. In this particular patient, we are injecting approximately 0.5 cc's to enhance the results there. Next, we will work anteriorly. I'm avoiding this little bridge in between as we see some fullness right in between. We will now work in the buccal area, and we will use something a bit softer. Here I think it is very difficult to treat with a needle because again we do not have a backing to our treatment region, and thus it is easier to fan a product such as Volift we're using in this case in that subcutaneous plane. Cannula is fanned in a subcutaneous plane in order to distribute the product in an even manner in this buccal region. Thank you. 0.5 cc's were used in this secondary region. Alright, a further additional 1 cc of hyaluronic acid was used in the submalar area and the lower cheek area in order to improve the volume loss and create a smooth transition. The product is molded and blended in order to, again, ensure that there are no irregularities, as well as a smooth transition between the anatomical subunits. At this juncture, we have supported the outer corner of the eyebrow, elevating it slightly, improved the hollowing of the lateral canthal region and entire infraorbital region, added volume to the midface, as well as lateral face and zygoma, and then importantly added volume back to the submalar regions, both anteriorly in the buccal region and posteriorly overlying the parotid gland. This creates an elevation of not only the upper face and zygomatic areas, but creates a softening of the transition between the eyelid and the cheek, as well as an elevation and support of the jawline itself. The next element of our treatment will be into the chin region to add support. We can see that there's increased tone and increased contraction of the mentalis muscle, which can also be treated off-label with injection with neuromodulator. But we need increased support here to improve the posture of the lip and increase the projection of the jawline in itself. Following that, we'll be treating the actual lip itself. Our treatment proceeds with treatment of the chin region and labiomental regions by adding some volume back. We do not want to create width in a female chin, we actually want a narrow apex. But on side view, we want to increase her projection to improve the contour of the lower jawline. This is again done with a cannula, and it is one of the tighter areas for patients as the cannula passes. The fibrous attachments of the mentalis muscle are adherent, and thus there is generally a sensation of pressure as we work in this region. Small amounts of filler are used. Here we are using Voluma, and this is in a deep subcutaneous plane. Once volume has been added to the superior sulcus, we then address the chin itself, and we will start right centrally by adding volume augmentation in the central chin. Typical volumes in this region will usually be approximately 1 cc per side for both the sulcus above the chin and the chin itself. We can see that treatment of the chin, we've treated this side of the chin and the labiomental sulcus as well, has obviated the need to treat the labiomandibular fold itself, which we can see on the opposite side. Typically, it is difficult to treat these folds in an effective manner when we are primarily injecting HA into the region. This can create fullness and also add additional weight in this region, making the appearance different but not any better. By improving the causative factors, which are lateral mid-face support and inferior chin support, we are able to elongate the jawline and add the support back to soften the crease compared to the two sides. For the lip region in this young patient, there's many different ways to treat lips. We can treat with a cannula, we can treat with the needle that comes with the product. One of the effective ways, particularly in young patients where they already have good anatomy, good definition, have a defined vermilion border but may need enhancement, is often to use a microbolus technique. Off-label, we will split the product into a insulin syringe with a 31 gauge needle with a very short needle on it and create vertical pillars rather than horizontal transition of the product itself. We must keep in mind the labial artery, both the superior and inferior, that tends to originate off of the facial artery in a 1.5 centimeter radius just lateral to the oral commissure. The superior labial artery can traverse in very many different directions in different patients. Most commonly it will be slightly above the vermilion border and then crossing the vermilion border to become just inferior to the border around the junction of the lateral 2/3 and medial 1/3 of the lip. The depth of the superior labial artery is typically about 3 millimeters. We keep this in mind when we're injecting. Number one, to avoid inadvertent injection and intravascular complications with hyaluronic acid, but two, to minimize bruising as well. I will take the first vial of filler. This is Volift, which has been distributed into insulin syringes, spread into 4 0.25 syringes. This is typically 1 cc in total, of course, is typically the adequate volume for a single treatment for most patients. Certain patients with a more deflated lip will require more product. We want to avoid creating too much volume in the lateral portion of the lip, causing a sausage-like appearance, but also we definitely do want to address it to avoid creating widening of the central portion of the lip and a tapering off of the lateral. So typically we will start just shy of the lateral commissure, and the needle is passed in a very superficial plane just below the mucosa. The most important part with lip injections is to create a very small amount of injection with our movements. Large boluses will not be tolerated well and cause lumping and irregularity in the lip. Thus, a very slow, deliberate injection is advised. As we come up the vermilion border, we pass an anterograde injection, and then in a retrograde fashion, I will be injecting the actual body of the lip in a more vertical direction. We continue to march up along the vermilion border. Patients usually feel more sensation as we come medially, and then we deposit more vertical boluses into the body of the lip as we continue medially. This technique tends to minimize bruising when done carefully, and also allows us to have very accurate boluses of hyaluronic acid in a very smooth and controlled fashion. We always like to enhance the Cupid's bow, and thus a direct injection into the peak of the bow is advised, as well as a small injection just lateral to the philtral column. It is important to measure accurately the amount injected into each portion of the lip, as the previously treated side will get slightly swollen and it becomes difficult to measure in terms of visual amounts of injectable. Thus, the filler is broken up into equal aliquots, and as we inject, we try and create a very similar pattern in somebody who has symmetric lips like this patient does. Our injection is slow. It continues up the vermilion border, and then in a diagonal or more vertical fashion adds volume to the body of the lip itself. And the Cupid's bow is injected directly, as well as the philtral column. The central tubercle of the lip is injected directly in the middle in order to avoid a sausage-like appearance laterally. The lower lip is treated in similar fashion. We desire to create a lower lip that is slightly fuller than the upper lip. Here, vertical threads of hyaluronic acid, in this case Volift, are distributed in small vertical passes fairly superficial plane, just at the junction of the mucosa and the orbicularis muscle underneath. After completion of the injection with the lips, it is very important to mold this and blend the hyaluronic acid well in order to avoid irregularities, both visible or palpable. So in summary, for this 36-year-old woman, we started with a comprehensive treatment, smoothing the transition in the temporal region and creating a slight brow lift with temporal injection. The zygoma lateral midface and medial midface were accentuated with a combination of voluma and vo lift for this patient, and then the periorbital region in the infraorbital hollows were treated with a lighter filler such as Volbella. The predominant amount of volume in this patient went into the submalar regions on both sides. The patient had a lot of volume loss and deficiency in both of these regions, both anteriorly over the buccal region and posteriorly over the parotid, and thus a combination of a thick high G' filler laterally for lift and a more soft and moldable and forgiving filler were used in the anterior buccal region. Finally, we enhanced the chin to increase projection of the chin and strength of the chin, as well as eliminating a central dimple that she had, and then accentuated the lips in a microbolus fashion with Volift filler in this case to create more projection and definition of her lips. This treatment is going to focus on periorbital restoration in a younger patient. Her patient that we are treating for this session is 27 years old, so this is not necessarily an age-related or aging process, but rather a congenital process that is leading to a more tired and hollowed appearance around the eyes. When we look at this young patient, we see that there is deficiency of not only the area around the orbital rim itself and the orbital hollow, but we see deficiency most notably of the medial maxillary region and support of the midface that extends all the way from the medial to the lateral aspect. Our algorithm for treatment of the infraorbital hollow includes augmentation and support of the lateral cheek, support of the medial portion of the cheek, and then finally direct treatment of the infraorbital hollow itself. Important landmarks in the infraorbital region include the lid-cheek junction, as well as the important vascular structures, most notably the angular artery and the infraorbital artery, which comes from a foramen that is approximately 1 centimeter inferior to the orbital rim and roughly consistent with the medial portion of the pupil. Injecting in this region, we will typically use a cannula in order to avoid inadvertent intra-arterial injection, as well as to minimize bruising and maximize comfort for the patient. Looking more specifically at the infraorbital hollow, there are two major components to this. This is the true tear trough itself, which is defined.
Video đến đây đã kết thúc. Nếu các bạn và các anh chị thấy hay, xin cho mình một like và đăng ký kênh để có thể cập nhật các video tiếp theo một cách sớm nhất. Giờ xin chào và hẹn gặp lại các anh chị và các bạn ở những video tiếp theo nhé.